عليكم. Inshallah, today we will continue our curriculum. We will shift to shoulder exam. One of the points which forget to mention in the last topic, which is lumbar disc disease. We have two types of routes, traversing and exiting. I inform you in the part of anatomy that we name the route according to the number of the pedicle. So if I have L4 vertebrae, this means that its pedicle, the route which passes just medial and below to the pedicle is L4 route, and it exits the pedicle at this level. L4 route passes medial and inferior to the pedicle of L4 and exiting. Okay. The spinal cord passes in the center and roots coming to the right side or to the left side and to the right side. There is other root coming and exiting at L5 pedicle, below L5 pedicle. So this is exiting L4-5 level, and this is exiting L5 root, exiting at L5 S1. But this is traversing to L4-5, and this was traversing in the level above 3-4. So each route can be exiting and traversing, exiting to the same level, at the same below the same pedicle, and traversing to the level below. Again, the spinal cord inside. This is a root, and this is a root. This is exiting for this level and traversing for the above level. So if this is lumbar 4 vertebrae, it will be, this root will be the left side L4 exiting, and this will be 5 exiting and traversing to this level. So to the same level exiting, the same number below the same pedicle, and if traverse the same level to the level below, it is called traversing, but exiting to the level below. Exiting, and this is traversing to L4-5, but it is exiting to L5 S1. Again, the same system. I am Ahmed ELattar, an orthopedic surgeon. Can I take some information from you and examine you? This is the consent. The same system as we inform you in the spine. The same history. What is your name, age, sex, location, smoking or no? The main complaint. 4 main complaint: pain with stiffness and stability, instability and deformity. Actually, deformity appears in the scapula itself, but in the shoulder, in the form of swelling, very difficult to detect. Swelling can be detected in the knee, very difficult in the hip, but here the main complaint is pain and stiffness and instability. As usual, pain you will analyze as usual. Do you feel a stiffness? You ask to detect mainly a rheumatological disorder. Then in the shoulder, frozen shoulder. If he feel that he has limitation of movement, it may be frozen shoulder. And instability in the shoulder is very important. Do you feel that your shoulder joint is stable when you move it, or you feel that it will be bob out? Okay. Associated symptoms the same as before. We're asking about numbness and weakness, constitutional or other joints like hand and cervical. I inform you in the spine before spine lecture how to differentiate between if a shoulder, if the pain is coming from the spine or the shoulder. For example, simple tests like a movement in the shoulder. If I have no pain, so usually shoulder is painless and has no pathology. All that symptomology, how it is affect his other activity of daily living. For the shoulder, combing and self-hygiene. So, and for that period, what you did, what type of investigation and type of medication you get. As usual, starting the examination. Remove the t-shirt. Exposure for each compartment or each region is very important. Don't try to leave a single piece of clothes on the examined site. I mean, don't be ashamed if it is a female for female or male for female, because you will miss even an important clinical finding or for your real life, or in the exam. I'm sure that you willing to pass this exam session. Okay, as usual, we're starting not to forget splints and gait. Then begin. The patient is removing his shirt and sitting, standing in front of you. Then begin, after splints, commence on splint and gait, you start with inspection. Inspection, front, side, back. And compare to the other side. Please don't forget infraspinatus atrophy. Don't miss infraspinatus atrophy and the scar. Don't forget infraspinatus atrophy, which is a muscle below the spine of scapula. Infraspinatus, you will compare to the other side by your eye. You will feel like some grooves, big groove in that region. Palpation, you start by suprasternal notch, then coming to the clavicle, then lateral end of the clavicle, AC. Below 1 cm is the coracoid. If you press hard, it is usually tender. Then the biceps tendon is between the GT and the lesser. If you do like this, external and the internal rotation, external and the internal rotation of the shoulder, you will feel a cord like in the groove between two prominent bones. This is the greater, and the inner one is the lesser, and the biceps tendon in between. Then to the spine of the scapula. So train yourself. Palpation from here, suprasternal notch, then the clavicle, AC joint, coracoid, GT, bicipital tendon, then spine of the scapula and medial border of the medial border of scapula. Please don't forget the axilla. Axilla is an important part, has an anterior wall, anterior fold, and posterior one and the floor. Please palpate. This is a palpation. Actually, I combine shoulder exam is very difficult, and I think it is complicated. So for me, this is my system. I combine movement and the special tests. Now the patient in front of me, the t-shirt is off, and starting with palpation and going around the patient, front, side, back. Then start with movement. This patient till now is standing. Forward elevation. I inform the patient, actually we supposed to do both active and passive. But if the patient doing the full range of motion active, why I will do passive? If he has a leg in active test, so you complete the movement with your hand. After stabilizing the scapula, you complete the movement with your hand. So you don't go to passive movement except if leg or incomplete active, or there is a weakness in the movement regarding the shoulder. Shoulder has flexion, abduction, external and internal rotation. So these movements we will do and examine. Okay. Forward elevation, which is flexion. Forward, I ask the patient to do a forward elevation of his upper limb. In that movement, I combine with both two special tests, Neer test and Hawking test. He is doing like this, forward elevation of the both upper limb. Neer test, I complete his movement and compress the greater trochanter, greater tuberosity against supraspinatus. So he feel a pain. So with forward elevation, I will augment with Neer, put my hand to elevate his like this, and feeling the pain or no. This is a Neer test and one of the impingement tests. This is one of the special tests in the impingement test. Then, with his elevated forwardly, I do internal rotation. This is another type of impingement test. So, with forward deflection, with the patient standing in front of me, I doing two tests. Neer test and Hawking test, plus active elevation. Two tests, special tests, which is an impingement test. We will add impingement sign after that with the injection of steroid. So the three tests of impingement is finished with forward elevation. Okay, side elevation, then down and side elevation to the side. Side elevation also has two tests. Side elevation, abduction like this, okay? He is doing. Then I do Jobe test, taking his upper limb about 15 degrees from neutral. About 15 degrees. Because the other test 15 degree in abduction. So 15 degree in abduction and 15 degree in adduction. This is called Jobe test, and this is called Obrein test. Jobe test is isolation test for supraspinatus. You have 4 major muscles in the shoulder affecting your decision. Supraspinatus, infraspinatus, subscapularis, teres minor is a very, very, I think it is very compensated muscle. They have infraspinatus can do its job. So I remove it from the rotator cuff and put biceps tendon. Biceps tendon, intra-articular part of the biceps tendon is very important. So we have for the shoulder specifically supraspinatus, infraspinatus, subscap. This is my philosophy. You don't have to follow it exactly. You can modify your approach. Do your approach as you want, but this is my thinking. How to hold the region inside your hand and do little to gain a lot of information. A lot of doctors has a lot of special tests and maneuvers, but a data they can't gain because they have a lot of tests. You have a specific tests. Try to collect this knowledge. Don't forget any exam for the patient to, as I informed you before, to be a safe surgeon. Have a good diagnosis with good decision. Okay, so side elevation to the side, abduction to the side, then 15-degree abduction, then 15-degree abduction. Jobe test and Obrein test. This movement could be supraspinatus and deltoid, but that movement which is abduction and your thumb is down and 15-degree in that plane of abduction, you isolate supraspinatus only and you will resist. This is a strengthening test for rotator cuff. You put a strengthening test inside active movement. He do side elevation, then empty can test to do supraspinatus isolation, then Obrein test in the adduction. And let him with the thumb down also and 15-degree adduction and let him resist. You are pushing down and he is pushing up. If he feeling pain, it could be slab lesion, as we will tell later, or AC joint. Okay, so we did another two special tests. One for the rotator cuff strengthening test, which is Jobe test, and the Obrein test to test slab lesion and the AC. This is the Obrein test in 15-degree adduction, the same position, but in adduction. Okay. Then, so forward elevation and two tests, side elevation with two tests, then to the side. To the side, I want to examine his infraspinatus to the side. I try to do external rotation and put my hand there to resist him. He can do external rotation or no. In adduction is infraspinatus Jobe. In adduction is infraspinatus Jobe. Okay, so this is a rotator cuff strengthening test. Jobe test before, and this is infraspinatus. Then belly press test with his hand in front of his abdomen. With his hand in front of his abdomen, like this, and his elbow in front of his trunk. Press his belly. This position, which is in front of his trunk, the elbow in front of the, just to make the movement coming from the shoulder, because he can press his abdomen from the wrist and from the elbow. So, but the fallacies decrease once you make his elbow in front of his trunk. So abdominal press belly test is done in that way. This is an internal rotation. This is for subscapularis. So after forward elevation and two tests, after side elevation with two tests, we did an external rotation in abduction and internal rotation test, which is belly press test. Just be in harmony Just be in harmony. The patient now in front of you. Then you will be in the back and do lift of test. You will put, you make him to put his hand on the back. This is an internal rotation movement away from his back and maintain this position. If he can't maintain either pain or weakness, you can do a strength. This is another way for subscap. Subscap testing. You can, this is without any resistance. If you put your hand on the palm, resisting him, trying to push his hand to his back, this is a strengthening test for subscap. So we did 3 tests for forward elevation, then 3 tests for side elevation, then external rotation in abduction, then belly press test, then to the back. So I did now supraspinatus tests, infraspinatus, subscap. Actually, after this test, I will go for biceps. I inform him to do speed test and the yerguson test, and feeling the tenderness in the bicipital groove again. After these tests, I will, still the patient in front of me, I will do a speed test and yerguson, but later it will be in this session, it will be clear for you, but just for harmony. While the patient, after finishing this all tests, I do a push wall test. After doing all these strengthening tests, I do push wall test. Push wall test is for detection of the winging of scapula. So again, supraspinatus, subscap, infraspinatus, and biceps testing, speed and yerguson, then push wall test. Okay, again, special tests which are combined there. We did Neer sign and Hawking sign, both in the forward elevation. And I inform you that the remaining test for impingement is impingement test by injecting a lidocaine, by injecting some steroid. And there is other collection which is rotator cuff lag signs, which testing test and the lag sign, which I informed you before. Just to collect, because the examiner can tell you specify to do something isolated. Lateral tests, we are informing you about Obrein, and there is another test which is crank test. Instability. Then after that, all this collection, then push the wall after bicipital tests. Push the wall, then instability tests for me, I do it supine on the couch. So all that tests was done during standing position. Then biceps, then pushing the wall, then supine to do an instability tests, which I will inform you again. AC was through Obrein test, which was in abduction 15 degree, either slab or AC. This is in advance later. Just I want you to hold all the chapter of shoulder in front of your mind, then details later. Labral lesion, we are informing you about Obrein test in the side elevation. Crank test is another one. Just doing an axial force in abduction, axial force, you are cranking the humeral head against the labrum. If he has a pain, so it is positive. Bicipital tendon, as I inform you, speed and yerguson, and the tenderness here. Speed test only forward the elevation like this, and feeling if he has a pain proximally. Speed test is like this, and the yerguson test, you are shaking his hand and resisting. He are inward resisting and you are outward resisting like this, and feeling the pain and move. AC, we are taking Obrein test. There is also another similar test which is cross body abduction to the other side. To the other side, you are pressing firmly the AC joint. Then the patient on the couch supine. All the tests for me are doing while standing. When I going to the last test which is instability test, it will be on the couch. Instability test is either anterior or posterior or multi-directional. Instability as a grading system, just to the rim is 1 plus, 2 plus. Over, they pass beyond the rim, but you can reduce if looked. This is type 3. Okay, anterior instability is anterior drawer like this. You holding the arm between your thumb and other fingers, and forearm in your axilla. You fix the shoulder with the other hand and pushing anteriorly, and you feel with your thumb the degree of translation, which is 1 plus, 2 plus, or 3. Apprehension test, when he is supine like this, still we are all supine. This is the anterior drawer. Then apprehension, just external rotation and abduction as this. Please be careful not to dislocate his shoulder, or if old age to prick his humerus. Be careful, please. After doing external rotation and abduction, this is a position of anterior dislocation. If he feel pain, it will dislocate. So you put your hand in the other figure to push the head. This is a relocation test. It's more sensitive. It's more sensitive than anterior drawer. Anterior drawer, then apprehension test. Actually, I do anterior drawer. Practically, I do anterior drawer, and if it is, I feel that everything is okay, I can go to apprehension test. I didn't start with apprehension relocation test. For me, anterior load and shift test, the same test is done for loading. Is loading the humerus against the crank test was loading the humerus in full abduction. This is in about 40 degree of abduction and forward deflection, then trying to push against the head, and the head relocate anterior load of the head and the glenoid, then shifting it anteriorly and posterior. This is test done for the anterior dislocation and the posterior dislocation. So, and loading is loading the head in the glenoid, and the cranking is cranking the head inside the glenoid. The multiplicity of the tests indicates that the sensitivity and the specificity of all tests is very low. So you have to do some tests beside each other to increase the sensitivity and specificity. Posterior dislocation, as we do the anterior drawer, you can do the posterior drawer. Anterior drawer, as you see here, anterior drawer is like this. If you push back, it is posterior drawer. Anterior load and shift test. If you doing in that position anterior shift, this is for anterior subluxation or instability. If you do posterior, so it is posterior. Jerk test in the supine, not in the standing. You doing forward flexion 19 and flex the elbow and push the elbow back, trying to dislocate the humerus posteriorly. This is a jerk test. Sulcus sign, once the patient is supine, you you pull his upper limb down and to open the space here between the acromion and the humeral head, and according to this bit in multi-directional instability, the patient has multi-ligamentous abnormality or maybe bony, so his shoulder is coming down and the space is open according to the degree 1 to 2 and more than 2 centimeters. I hope that I made this chapter easy for you. Again, do your system, but be in harmony. Try to make the patient stand once and sit once. And for me, I find this is the most appropriate, which I can do all tests with ease. Second tip is to isolate tests to its category. You can be asked about instability tests only. You can be asked about rotator cuff strengthening only. There is a little term which is called lag test. Lag test for rotator cuff. Lag test means that this muscle is lagging her action. So, if supraspinatus, for example, the lag test for her is elevating him and leave him, so his arm will drop. Drop arm test is a lag test for supraspinatus. If you do external rotation, if you do an infraspinatus test, which is external rotation against resistance, you hold that position. If he can hold, so he has no lag sign. But if his arm is going down like this, he can't to hold the external rotation action, so it is a lag test for infraspinatus. Subscap, which I tell you, the one which is below the back. You try to hold the hand back to his back, but if he can't maintain this position and his hand, dorsum of the hand, touch the back, so he can't hold this position, so the subscapularis is dead. You is going to the lag test when the muscle is completely lost. Actually, it will be very rare, but just for you or in a matter of exam, lag test is the test which is the muscle is gone. You are holding the position of the muscle and inform your patient to maintain their position. I trying to make the important first, then the less important. Also for teres minor, he tell you Hornblower test. Hornblower test. You maintain external rotation. Teres minor is as infraspinatus doing external rotation, but in abduction. If he can't hold this position in external rotation and his shoulder internally rotate, so he can't maintain external rotation in that position, which is mostly done by teres minor, it will be lag test for teres minor. teres minor. So you know 4 tests for strengthening for the 4 rotator and 4 leg tests for the minor. Thank you, and we will go on. Continue.